Welcome back to Hot Flashes and Cool Topics. Today we have on Dr. Sharon Malone. And as we mentioned, she is one of the nation's leading obstetricians, gynecologists, and now the chief medical officer for Alloy. Welcome to the show.
Thank you very much for having me.
Well, we appreciate you taking the time because the topic we wanted to talk about today was kind of what happens post-menopausal. So you have those great 12 months where you don't get a period and you celebrate on the day, but what happens after that? So many women think that magically all of their symptoms are going to disappear, and that is certainly not the case. Could you talk a little bit at first about what post-menopause is so that we have an understanding of where we're going?
Sure. I think that just the term postmenopausal is actually somewhat of a misnomer because you are menopausal forever. So the average woman will live anywhere from 30 to 40 years after they have had that last menstrual period. And the only reason why 12-month anniversary is important, it is only to let women know when bleeding is abnormal. So until you have gone 12 months without a period, anything is fair game. You can have a period once every 3 months. It can last for 2 weeks. So that is sort of our sort of medical demarcation between when bleeding is normal or abnormal. It has absolutely nothing to do with the symptoms that a woman may or may not have from that point forward.
What happens when you brought up bleeding abnormally? And we've heard from different people. We have a Facebook group that they maybe haven't had a period in 2 years and then they're bleeding again. So is that considered abnormal bleeding?
Exactly. Anytime you've gone for 12 months in a row and you have not bled and you bleed again, that is a signal that it doesn't necessarily mean that there's something wrong, but it means that that needs to be investigated. Unlike if you've not had a period for 6 months and you have a period again for another 2 or 3 months, okay, we will put that, you will chalk that up to being still in the menopausal transition. But the reason why we sort of hold to that is because one of the cancers that comes up in women, postmenopausal women, is endometrial cancer. And it has a very early warning sign, and it is very often curable. And that sign is postmenopausal bleeding. So that's why we don't want to sleep on any bleeding that has happened more than 12 months after the last period.
I know that we have seen a lot of, I read a report recently that the UK did research on menopause queries in Google, and the second most frequently asked question is postmenopausal heavy bleeding. So it does seem to happen more often. What about the relationship with HRTs and the bleeding after you have your period? Is there any relationship that you should be concerned with about that?
Well, again, this is something where it's a little bit of art as opposed to science, because most women who start hormone replacement therapy are starting it because they're symptomatic.
Mm.
And it would be cruel and inhumane to say to a woman, okay, well, I know you've got terrible symptoms, but let's wait 12 months to see if you really have had your last period before we start therapy. That's really not the way it works in the real world. In most cases, women will start the hormone replacement when they are most symptomatic. And when, and it may be you haven't had a period for 3 or 4 months or 6 months, and you start hormones. Well, how do I know that, you haven't had your last period already? If you're going to get another period 3 months from now and you start hormones, you're still going to get that period. So, it can be confusing in the early phases of starting hormone therapy. And that's why I said within that first year of initiating therapy, any abnormal bleeding or any bleeding that you have, yes, inform your doctor. And they may say, well, sure, let's just keep an eye on it. It is much more problematic if you've been on hormone replacement for 3 years and start bleeding, not within that first initial period, because usually we give you about a 6-month grace period from when you start hormones as to whether or not we get excited about any bleeding. Usually there's a simple explanation for it.
I had a situation similar to that, and they changed the estrogen that I was taking, and I started bleeding again, and I was terrified. Then they've dialed that back a little. I'm just hoping that's something that is common there.
Right. And it
Mm,
is. And I think,
mhm.
but they're very simple ways to answer that question. Sometimes it's just as simple as getting an ultrasound just to make sure that the lining of the uterus looks okay. And you go, okay, looks great. Don't worry. Hang in there for another few months before we do anything sort of invasive or any biopsy type testing. But some common reasons why women can bleed when they're on hormone replacement is sometimes just forgetting to take your dose, because if you start skipping and you're like, oh, did I take my hormones? And it's been 3 or 4 days since you had your last dose. Usually a hot flash will remind you of that. But sometimes the first sign will be some bleeding that you may or may not have had. And I'm going to take you way back to the old birth control pill days. The reason why you get your period when you're on birth control pills, it's you take the hormones, your estrogen and your progestin, which is the same basic components that are in hormone replacement therapy. In the old days, you would take them for 21 days, stop taking them, and your period would come. And it's the withdrawal, the taking the hormones away, that triggers the bleeding. That's what causes a period when you're on birth control pills. Well, imagine when you're on hormone replacement therapy, the same thing happens. If you've been taking your hormone therapy, every day, and you forget it for 3 or 4 days, it may trigger that same sort of withdrawal bleeding, that will give you a slight period where you may not have gotten one had you been taking your doses as scheduled. So that's why I said, don't ignore it. But if you're beyond 6 months, into your hormone therapy, it is worth a conversation, at least to say, hey, should I be worried about that? And what can I do to figure out whether this is something I should be concerned about or not?
How long should women stay on HRTs once they are postmenopausal or menopausal, but past the 12 months?
Exactly. Now, isn't that a good question? I mean, it is an excellent one, as a matter of fact, because it's one that we've bandied about for 20 years. And I think since the Women's Health Initiative came out in 2002, the recommendations were so nebulous. It sort of said women should be on the lowest dose for the least amount of time. Well, that's as clear as mud, right?
Exactly.
How long is that? We know when you're on the right dose because you're on the right dose of hormones when your symptoms go away, and that's sort of usually what we will titrate to. For women who are having either sleeplessness or hot flashes, we know you're good when you say, all right, that's it. Symptoms are gone. But the how long piece of it has been a matter of debate. The Women's Health Initiative got stopped at 5 years for women who took estrogen and progestin. So they don't know how long is too long or not. And so that sort of guidance was not very helpful. But the good news is that the North American Menopause Society just recently came out with new guidelines. And it said two things that are really important. One is that there is no need to routinely stop hormones at any particular age. And they use 65 because some doctors would say, okay, you're on hormones, you're doing great, but you're getting older, so let's stop them. And the North American Menopause Society and the American College of Obstetricians and Gynecologists has said, there's no science behind that about routine discontinuation of hormones. As long as you do not have reasons that you should stop, such as breast cancer or a blood clot or undiagnosed bleeding. Those are the hard stops for everyone. But if you are healthy, you haven't had a heart attack or stroke, and you are doing well and you wish to continue your hormones, that is an individual decision between you and your provider. But that was, I think, very, very important information because that it has sort of gotten out there in the world that women could only take for 2 or 3 years, or you should stop by 60, or you should stop. And all of that really was based on no science It was just someone's interpretation of when is the least amount for, the shortest period of time. And everybody had a different answer for that.
You brought up some interesting things in there when you said the breast cancer, the heart attack, the blood clots. And we get a lot of questions from our group and our listeners about that they want some form of relief, but either they have had breast cancer or their mother had breast cancer. Are there solutions out there for women like that?
Yes.
Mhm.
But let me sort of back up a little bit and to tell you who actually cannot take hormones. And if you personally have had breast cancer, then you are not a candidate to take hormone replacement because, we can debate whether or not that is true or not. But I think that's a safe middle of the road place to go. If you have had breast cancer, no. Now, I think what's more common is you have a family history of breast cancer. And here is also some very good news that came out of the newest recommendations from North American Menopause Society. A family history of breast cancer is not, and let me underline not, a contraindication to taking hormone replacement. And I think that a lot of women think that because their mother had breast cancer or because a sister had premenopausal breast cancer, that they cannot or should not take hormones. And basically, what we have now the benefit of knowing and watching these 20 years since the Women's Health Initiative, what we found is that is not a family history is not a contraindication. For every individual woman, your risk for developing breast cancer is what it is. And the question is, how much does adding hormone replacement therapy after menopause add to that risk? And I think we can say safely now is that risk is minimal to non-existent. Now, I can't tell you you won't get breast cancer because your risk is your risk. But let me put it in terms of even from the worst case scenario, the Women's Health Initiative, what would the attributable risk of taking hormones be? And this is worst case scenario, not even the later data. Taking hormone replacement therapy after menopause increases your risk, the equivalent of drinking a glass of wine a day, of being overweight, so there are a lot of things that are, again, as risky, when I say risky, and I'm using that in the worst possible way, but you know what I mean? It's not as if you would say to a woman that when someone says, and this is sort of how we got down this path, when someone says your risk of developing breast cancer is elevated by 26%. Sounds horrible. Who wants a 26% increase in risk in breast cancer? But what does that really mean in terms of your overall absolute risk? And what a 26% increase means is that if you take nothing, if you're on no hormones whatsoever, and you're at average risk of breast cancer, your risk, the population risk of developing breast cancer, 30 women per 10,000 will develop breast cancer in 1 year. What if you look at again, worst case scenario, the synthetic progestin and estrogen? What does that risk go up to if you take hormones? And the Women's Health Initiative said that risk went from 30 per 10,000 to 38 per 10,000. So you're talking about, in the worst case scenario, an additional less than 1 per 1,000 women per year will develop breast cancer, arguably because of their use of hormones. And that doesn't sound nearly as scary as a 26% increase in your risk of breast cancer. So that's why I said you have to be really careful when you're looking at statistics. You really have to say, okay, well, if I told you buy my Lucky Charm and you have twice you have twice the chance of winning the lottery, the mega power, the Powerball. And then you said, okay, well, your choice was 1 in 100 million. Now it's 2 in 100 million. You wouldn't want to buy my charm because guess what? You're still probably not going to win that lottery. And that's what I want women to think about when they think of breast cancer, because the news keeps coming out And it gets better and better because it depends not only upon the timing, the age at which you start hormone therapy, but it also depends upon, what your other lifestyle risk factors are. Not exercising, being overweight, drinking 2 or more glasses of alcohol a day. But no one's advocating, oh my God, alcohol should be banned, or women should, not drink. I mean, these are all sort of calculated decisions that we make. And I think that that has been the biggest issue I've had, is that so much about whether or not to do or not do, or take or not take, has been dictated to us. And I think that women have they should have the agency. And given the proper information, you can decide. And that's all I ask, because I'm here not to advocate necessarily for hormones or no hormones. I'm here for making sure that women have the information that they need, proper information, not skewed data that makes you fearful. You should be making the decision to do hormones or not do hormones based on how you feel, what are your expectations, for how you would like to live your life. And quality of life is not insignificant. And that in and of itself should be the beginning and end of the story. But there really are long-term health benefits for women who take hormone therapy: decrease in the risk of osteoporosis, decrease in the risk of type 2 diabetes, and decrease in the risk of recurrent urinary tract infections, sexual dysfunction, painful intercourse. All of these things sort of go into the decision to take or not take. So I have just always been dismayed that that conversation has really not been a two-way conversation. It's been someone saying yes or no, or a doctor telling you can't have this, or women automatically taking themselves out of the conversation, thinking that they can't take it because my sister had breast cancer, or my 80-year-old great aunt had breast cancer. And that absolutely should not be a deciding factor.
With the hormones now at a lower level, now that you've gone through those 12 months, do some women find that their symptoms start to get a little bit easier because the hormones are now level, as opposed to the roller coaster ride you're on in perimenopause?
I'll tell you, there are a few things that do get better eventually. The brain fog that women complain about a lot during the perimenopausal transition, that's the worst. Some of the mood disturbances that women have, the sort of, that up and down, depression, anxiety, for women that do not have a pre-existing, condition of depression or anxiety, we'll find that some of that tends to settle down. The hot flashes eventually settle down. But when I say eventually, hot flashes can go on anywhere from, not at all for some women, the lucky few that don't get them. And some women are still having hot flashes into their 70s or 80s. Now, they're the outliers on both sides of that. But the average woman will have hot flashes anywhere between 4 and 10 years. And all the resultant complications that happen after that. Sleep disturbance, if you are having hot flashes and night sweats that keep you up at night, you're not going to sleep well. You are not going to perform well the next day at your job. It's going to worsen brain fog, and your mood. I can assure you, for someone who's spent a big portion of my career getting up in the middle of the night and being up all night and having to work the next day, it does not put you in a very good mood. So it's probably better for all involved that you get a good night's sleep. But those things, and this is what I'm saying, these are the things that tend to get better. The hot flashes get better. The moods tend to settle down. The brain fog tends to just get into normal, whatever an aging brain feels like, but it's not that intense brain fog. Those get better. However, there are things that get worse. And what are those things? Sexual function, even for women who have not had issues in the past, the vaginal dryness and thinning, the changes that are in the vulva. Some women complain of burning, itching vulvas. More urinary tract infections because your the microbiome, the bacteria that normally live in your vagina that keep your vaginal pH low, which is where it's supposed to be, changes. These are things that will happen and will continue to happen. You start to lose bone density. And when your estrogen levels plummet, that bone loss is most rapid in the first 5 years, within 5 years of your last menstrual period. That will continue. So that's why these are things that may be happening in the background that you're unaware of. The skin problems that women start to have. Women start to notice that there's more wrinkling, there's more dryness of the skin, there's itchiness, all of those things. And that's why it's important to know that menopause is not an event. It is a life phase that you will be in from the moment you've gone from that 12 months of your last menstrual period until the day you close your eyes. You will be feeling the effects of menopause and the changes in your body that accompany menopause forever. And again, a point that I really want to make clear is that menopause is not just, estrogen and lack thereof does not affect your reproductive organs. It affects everything in your body. Joint pain, the microbiome in your gut changes as you get older, and and there are estrogen receptors there. There are estrogen receptors in your eyes, in your brain. And I mean, you name it, and we have estrogen receptors in our body. And I think that we sort of spend a lot of time thinking of it as just a reproductive hormone. But no, as women or people who are born with ovaries, if you make estrogen, it is having its effects over your entire body. And once you no longer have that hormone, then you will start to feel the effects of that estrogen deficiency.
And that so many women don't realize that. They, just like you just said, so many women don't realize the role it plays in everything. And you brought up so many great things that it does affect, one of them being UTIs. We get a lot of questions about that as well. And I've seen, you wrote an article as well. I read about vaginal creams. Can you talk a little bit about that?
Sure. Because now here is the good news. Not everyone is either going to want to take or maybe does not need to take full dose systemic hormones. And by that, I mean either oral estrogen and progesterone or patch pills, creams, and sprays. Okay, so that's systemic. And that works best for women that are having, hot flashes, mood swings, all of those things. So, but there are some women who, again, that lucky few who get through the menopausal process don't really have a lot in terms of systemic symptoms. But as I said, there's the things that get worse. The vaginal issues get worse. The painful sex gets worse. Sometimes inability to have an orgasm. All of these things tend to happen later. And sometimes you don't link it necessarily to menopause. You just think, oh, I'm just getting old, and that's what this is all about. But it is intimately tied to that lack of estrogen. UTIs, now something you don't really think about, but your bladder also has estrogen receptors in it. So not only your vagina, your urethra, the lower portion of your bladder, all estrogen sensitive tissue. And as I said, not only the pH in your vagina changes, different bacteria start to populate your vagina. And those different bacteria, that you've lost your protective bacteria, and the others can cause urinary tract infections. And when the tissue is thin, it's more fragile. It's easy to cause damage or even just minor trauma. Women can sometimes have this, they're not even sexually active, and it's just wiping. Any minor trauma can, cause bacteria to get into places where it's not supposed to be. So urinary tract infections, whether or not you are sexually active, can be a problem, as well as urinary symptoms like urgency and frequency. inability to, it's a very common thing where women are like, oh, that whole, I gotta go. It's because you don't think about, but your bladder has estrogen receptors in it. And when you don't have enough estrogen, then that tissue gets thinner, weaker, and not able to perform as intended.
And does that take over time? I'm thinking in terms, honestly, personally, I'm now 9 months into no cycle. So I'm, waiting for that 11-month, 29-day period that's going to show up. But with fingers crossed, if I were to pass, would it happen over time that you would start to notice that thinning or the pain? Or is it something you notice pretty quickly after your estrogen goes to a minimal level?
No, it happens over time, because even if you don't have it now, you will be in a very different place 2 years from now or 3 years from now than you are today. And that's why I said people don't really think of it as a menopause thing, is because, or an estrogen or lack thereof, because it can happen many years after, as the tissue itself starts to thin and weaken. Now, and getting back to, I guess, the original question, Bridget, see, this is also what happens too. You start on one path.
I
Where
do it
was
all
I
the
going
time.
with that?
Oh, yeah.
And where we were going with your original question was, well, then what can you do about that? Hey, I don't have hot flashes. I don't have this other stuff. I'm not at risk for osteoporosis. I just have, vaginal dryness and urinary stuff. You can use topical estrogen. And by topical estrogen, I mean vaginal cream. But topical estrogen can be delivered as a cream, as a ring, the little silastic ring, as vaginal tablets. And the difference being is that the amount of estrogen that's delivered locally, right there to the vagina, is far less than what you would need if you were trying to deal with hot flashes. So you can take care of those pesky, painful dry sex problems, urinary issues, by just using a very low dose topical estrogen. And the key to that is that it needs to be used consistently. It's not the kind of thing where you take it, now I feel better, okay, now I can stop, because the condition is still there. And the minutes, like being Cinderella and it's midnight, when this clock strikes and you take it away, everything will eventually go back to the way it was. And for women who, and this is also, I mean, your timing is impeccable here, because I just recently, went through all the new guidelines from the North American Menopause Society. And basically there are almost no contraindications to using topical estrogen. Even they've come around to say that even for women who have had breast cancer, whereas you may not be a candidate for systemic estrogen, you can use topical estrogen because the dose is so low and the effects are, are life-saving for some women. I mean, it would be terrible that in addition to everything else, and particularly for, younger women and women who are sexually active, to say, well, too bad for you. We got nothing other than lube.
Mm-hmm.
Yeah. I wanted to kind of go into a little bit more about Alloy and the starting of the company. And what questions do you get asked from some of the clients that contact you there about postmenopause?
The biggest problem, and I think that Alloy Women's Health is trying to address, is this information. There's this lack of information. I mean, the fact that we are here in 2022 and we are still discussing, and women are still walking around with 20-year-old information from the Women's Health Initiative and thinking that is still the current, state of our knowledge. And it would be bad enough if it were just women who were misinformed. There are doctors that are misinformed. And unless you find menopause to be your passion, most doctors do not keep up with the current literature and about menopause and hormone therapy. So it is quite possible for even the fortunate woman who has an OBGYN or who has an internal medicine doctor who is coming in complaining, to have your doctor wave you off the most effective treatment for the symptoms of menopause. And that's unfortunate. And then there's the huge swath of women out there who live in areas that they don't even have access to an OBGYN. I mean, there are over 20 million women in this country of our, of a menopausal age who do not have an OBGYN that they have access to within their geographic location. And I don't think that any woman's information or their access should be limited by where you live. And that is why something, like Alloy exists. It is to provide information for all women. It is to really democratize that information such that, a woman who lives in New York City should have no less, no more information than someone who lives in Kalamazoo, Mississippi. I mean, there's just no reason why. And if you have access to quality information, and I emphasize quality because we all know there's a lot of stuff on the internet, but you don't really know how to decide what's a good source, what's not a good source, who's trying to take advantage. And Alloy is trying to be that trusted space for women. We provide community. We want to provide education, and then give you access if you do not have a physician who is either willing to prescribe hormone replacement therapy or you don't even have access to a doctor that could do it either way. So that's our reason for being. And I'll tell you what we are not. And I think it's important for women to know this too. We are not here to replace your doctor. We have a very specific mission, and our mission is to provide access to community, information, and medication for symptomatic women. Though that's why we're here. We are not your doctor. We're not your primary care doctor. Okay. There are things that we cannot do, and we do not discourage you. And actually, we encourage you actively to do all of the health risk mitigation things that you should do. See your doctor for a physical, get blood work, get your mammogram, get your colonoscopy. All of that needs to be done. And just if if we understand that, what niche we're really trying to fill, that's what Alloy Women's Health has done. And I've heard story after story after story about women, believe it or not, in New York City, who will go to their doctor and their doctor will say, no, you can't have it. Or yes, you can have it, but they will give you these compounded, supposedly bioidentical hormones. They charge thousands of dollars of blood work in terms of hormone testing, which you do not need, mind you, that's number one. And then we'll give you prescriptions for these compounded medications, which are not FDA approved, not inspected, not regulated. You have no idea whether what's in it is what they said is in it, nor do you have any independent verification that the amount is even correct. So I would say, sometimes you can have too much access, and that would be the case in large cities where you have these doctors and naturopaths who give women pellets and the like, and don't think for a moment that those are safer than bioidentical, commercially prepared hormones, because at least you know that they are manufactured to a standard, which you have no independent verification of for compounded products.
If a woman wants to contact Alloy, what is the best way to do this? And I also, another part of that, I noticed the products on Alloy, and how are they prescribed?
Yes, we use only FDA approved menopausal hormone therapy. We also use all of our post-menopausal or menopausal therapy is bioidentical, which all that means that is not the same thing as compounded. It just means that the hormones that we use are the same native compound that your ovaries made when you were making hormones themselves. So that's what we use for our hormonal menopausal hormonal therapy. We also use low dose birth control pills because it's a different, we didn't go into that today, but it's a different mission for women who are perimenopausal than for women who are postmenopausal. Perimenopausal women need usually control of bleeding. They need contraception in many cases. And so, as well as cycle control. So that's why the only reason why we do not use bioidentical hormones in perimenopausal women, because we use birth control pills, and there are no bioidentical birth control pills. They do not exist. And we provide, and we also have hormonal cream for the women who either, like I said, who can't take hormones, don't need them, but they have the urinary symptoms. And we also use, again, FDA approved a low dose paroxetine, which is it's usually used as a low dose, it's an antidepressant, but we use it a much lower dose than what you would use to treat depression. But it is for women who, again, are contraindicated, you cannot take hormones. And then we at least have something to deal with. And that is specifically just for hot flashes. It doesn't deal with any of the other symptoms.
For women who are postmenopausal, sometimes they're not sure how often they should go to have, you go for your yearly gynecological exam when you have your cycles, but once those stop, is there a standard where should you still be going every year, or can you go 2 or 3 years without?
Yes. I say go see your gynecologist every year. And I'd say up until age 65, there are things that we as gynecologists will look at that no one else looks at. Because if you see your internist, chances are you may or may not get a breast exam, and you are certainly less likely to have gotten a pelvic exam. And so see your gynecologist once a year. The older you get, when you get to be 65, you can see your gynecologist every other year, particularly if you have no problems, no issues, you're not on any other medication. But 2 years should be about the limit. And but the 2 years on the gynecologist front is predicated upon assuming that you're going to see your internal medicine doctor or your primary care doctor once a year. So if you alternate and you see your primary care, you're getting all your other stuff done, and you're over 65, because there's also, and you don't need a pap smear over 65, and that's one of the things that women are coming for, then, but there's never an age that I tell women that you absolutely do not need to see a gynecologist, because there are some things that do increase with age, even though they are rare, such as some of the, vulvar cancers, if no one's looking at that skin in your vagina and in your vulva, then how would you know? So every 2 years at, over 65, annually before.
And do you think with the increase of the number of postmenopausal women in this country increasing every year, there will ever be a time where a gynecologist will not be an obstetrician gynecologist? Because we do reach a point where we go in that office and I don't want to see the little rugrats running around and the pregnant woman and waiting because you're backed up because there was a delivery. Do you think there will be a trend towards just gynecology?
I think that, I think there should be. Let's put it this way. I probably spent the last half of my career, of my almost 30-year career, just doing GYN. And I focused, and even though I still saw women of all ages, I did see, a large part of my practice was, perimenopause and menopausal women. But I worked in an office with other doctors who were still doing OB. And that's kind of the nature of the beast. You have to bring in younger people to keep your office going. But there has never really been, and this is something that I think that we've got to work on, a specialty. There should be a subspecialty that focuses on women at 40 plus. We are more than just our individual parts. And it's not just that. And so women who have a particular interest, it should be almost, you would be a combination internal medicine, gynecologist, women's health specialist. This would be the specialty where you would come in and we would be able to have these kind of conversations that you don't get to have when you're trying to jam everything into a 15-minute appointment. And I've got to get this and that, whatever, and hurry up and get out of here because somebody else has to be in this room 7 minutes later. I think women deserve that. And I think that those are the powers that be have got to understand that women's health is much, much bigger than our reproductive parts.
Absolutely. We
Yeah, we
agree.
both said absolutely. Yeah. No, we agree. It is amazing that and I think I've seen you speak to this point too, that those years after you're able to have children until you're maybe really old, nothing goes on for us, or you just don't hear about it. But it is a desert, but you're hearing more and more about it. I feel like I have seen, and it could be because I was aware of it, I was seeking it because I was at that age. Do you find that in your 30 years of practice that the subject of menopause and post-menopause is becoming more prevalent?
Absolutely. And something has really happened, I think, in the past. Yeah, I mean, COVID, believe it or not, has opened some doors, of opportunity for us, because I think that we are at a real inflection point in medicine, and we have got to realize that the way that we deliver care is efficient for no one, not for patients, not for doctors. We are using a 19th century model for delivery of care in a technological world that all other possibilities exist. So, whether, there are certain things that obviously you need to go in for and have physical exams, but there are many discussions and I mean, we have all of this technology available to us, to be able for women to be able to go educate themselves, ask questions. Younger women are not going to tolerate, I'm going to call my doctor, be on hold for 25 minutes, take a message, somebody will call me back 3 days from now. That makes no sense, and we're going to have to learn how to adapt technology to make it work in medicine. And we are about 30 years behind on that, and that's because doctors, not only are we not good business people, but we are really not good technology people either. We're still, if I tell people this because it is true, were it not for the Affordable Care Act mandating that doctors go to electronic medical records, you would still be going to your doctor's office and they'd be writing in a paper chart somewhere that no one could access or read. Promise you. But you make, when you make people make that change and you realize, oh, okay, well, that was better. Well, we're now at that point now where we've got to understand the importance of telehealth, the importance of, asynchronous visits. For people who are elderly or infirm, getting to and from the doctor's office is a problem. And if I need to check in with you about something, we have technology that could help us with that. So that's why, it was such a fortuitous moment that as I ended my clinical career, that Alloy just sort of appeared on the horizon, because it didn't even require, any sort of directional change. I am doing what I did for the past 15 years, but I get to share this knowledge with a much broader group of women and not just one-on-one. And that's what we've got to do. Leverage the expertise and get it out there to as many women who are willing and able to hear it.
Well, we certainly appreciate you sharing your expertise today, because you answered so many questions that our listeners have asked us about postmenopause and the menopause journey. Because like you said, it could be 30 or 40 years, and how do you want to live it? So thank you so much, Dr. Malone. We appreciate it. Thank you for being on.
Thank you for having me.